For example, I open now anterior segment and click new. In the left side, you can see the actions here or the menu. You can enter a reason for encounter, the reason why the patient visit you, and diagnosis, and you can write your documentation. As progress note, for example. Testing. I click update here. All what you have entered for specific patient, it will be shown here for the specific visit, for the current visit, in the current tab. If you would like to add order or add anything or request OR, all of them from the left side in one screen, which is more simple than previous. Or request appointment, you can add whatever you want from here, from one single page. For example, if I would like to place order, so from here, update. You can see in the current tab that an order has been added, just confirmation. Okay, now the assessment, it's about the progress note and the plan, medication order or OR request or request a new appointment. We have icon here, a quick access for medication or lab order or operation. And the last icon here, it's for discharge summary for the medical reports and sick notes. It's just one click access. And it's like a previous one. It's a new layout. So what's new here in active clinical note? You can use the vision completed. You can add what, for example, ophthalmic assistant added. It's just one click here in the X button. So it will be added to your note. Just confirmation that you can see the vision and the medications order and the progress note in the same screen. Also, you can, if you would like to agree with other doctor opinion, you just, or other doctor note, you just click in this X. His note or her note, it will be added to your documentation. Okay. So after you finish, you can copy entry text here and paste it in Word and whatever you want. Here, copy entry text and paste it in Notes or Word. ما في وقت هنا. في مشكلة هنا في الكابي. Okay, I think they locked the copy in this laptop, but I tried on my computer, it's working. So again, if you would like to copy the entire first, you can just when you click here, copy entry text, and everything you entered here for the specific patient, it will be copied and pasted in anywhere you want. So what's new here also, you can check physician entry. It's not like a progress note. You can see in one screen that's what other doctor writes for medication or progress note or assessment and diagnosis. And also you can check your own entry for this patient. One more function, you can enter the patient file based on the problem. If you enter any problem that's related to specific entry or specific visit, you just click on the current entry, then click here across encounters. It's like a smart search. You can you can see here it's filter based the current problem. For example, here I can see only the visit for this specific problem. If you would like to search for specific word, it's like Control F, but in smart way also. If I would like to search for specific word, just here it is, find. Yes, you can search your name also here for any previous entry. And also we have here a clinically significant flag. It's like a safe patient, favorite patient. If you would like to retrieve this patient as, if you would like to mark this patient as clinically significant flag, you can just click here. So you can find this patient in your favorite list later. If you are familiar with the previous EPR, to read the previous data, you can click the icon here to check the previous enter data in the old way. It's available, but you can't enter any data from here, just for reading. So is it clear, or you have any other question? Clear? Okay, doctor. Yes. Once you open the new visit for the new patient, a pop-up will be shown like that to check all the old entries. Yes. And you have other option from physician entry. You will have it in 3 ways, from physician entry, or you can find it in the right side here. So always right side to read the previous entry. Here, all doctor notes, and you can read here. If it's small and you would like to read in bigger way, you can click this icon to open the doctor notes. But once you use the active clinical note, you can check it from here, physician, and here clinical profile. Yes, we have added a new icon for doctor notes. It's called assessment. If you mouse over the icon, it's called assessment. So starting from 1st of July, the old EPR, all the new button, it will be disabled. So any other question? Okay. Okay. Sorry? The templates? Yes. Doctor, you are working in which specialty? Medicine department? Yes, all the old templates, it will be shown here, but in the action. So we simplify the screen to be in one page. For example, here for do you mean the context? It's in the same way, just the quick access link, it's changed. Yes. No, it will be not affected. It will be the same for the context. Okay. Yes, you can review the medication from here, from this icon. From here. Here the medication and the lab and the ID, separated icon. Yes, doctor? Yes, it's the same. For place order, you can place order from here. All what you saved as your profile, for example, context, favorite order, favorite diagnosis, it will be the same. Yes. From here, current medication. You can select the patient and admin, reorder from the right side. Yes. Yes, yes. Yes. Also, you can retrieve any previous entered data, for example, what entered from ophthalmic assistant for the vision and IOB, you can just confirm that and enter it in your note automatically in just one click. Okay. 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 We will be there, Nick, to help you in this regard. You don't need to call 60 for the first patient. Then will be separated to the hospital. So is it okay? I think it's simple. Okay. Okay. Yes, you can find it here. Just one click access operative record, and you can see all the requests. Yes, it's the same. For the operation, it's the same. This is just for inpatient visit and outpatient clinic. OR, it will be the same. So is it clear? For the reduced number of patients, we will talk with the management. Okay. Yes, I think we... yes, it's the same. Just it will be AR visit, and it will have their own documentation for the AR. Actually, no more EPR in hospital, in KKESH hospital. It will be active clinical note for all the departments. But it's the same idea that you have to read the information from that right side and add any other information from the left side. And you can review from in the middle. So it's clear? Any other question? Okay, thank you.
بس عندنا وقت.
ايه خلاص تقترح من جديدة.
الله يكرمك، جزاك الله خير، بارك الله فيك. بسم الله. انسخه احسن ولا نفتحه من نفس الفلاش؟ ايش رايك؟ حطه سطح المكتب افضل. وننسخ الكويز كمان مرة واحدة. خلاص شيله. نجرب بس نتأكد إن شاء الله. أنا ولا أنت؟
أنا يس.
الله يبارك فيك، شكرا. في بوينت هذا؟ خلاص نمشي من اللابتوب. الله يجزيك خير، شكرا.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. كل عام وانتم بخير وحياكم الله بآخر Grand Round قبل السمر recession. Today we're going to have a really interesting topic that we see a lot in our clinic, at least in the oculoplastic clinic, and also it's a common condition that's been encountered in general ophthalmology practice, as Dr. Hattan gonna highlight on this when he gonna start his presentation. This grand round will be given by Dr. Hattan Khayari, who needs really no introduction because he's well known for our community for his contribution both in academic, non-academic, and also administration. And I will leave the floor for Dr. Hattan. And
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. Good afternoon, ladies and gentlemen. It gives me a great pleasure to present my review or my work in a very important aspect or topic in oculoplastics, which is punctal stenosis. Today is going to be the last grand round given before summer vacation. For my colleagues, the residents, one of the cases or the questions in the quiz will be from this grand round, so please pay attention. وممكن إذا تحبوا تنادوا الزملاء إذا في أحد برا ينتظر أو شيء. طيب, epiphora is a common complaint encountered by ophthalmologists with a broad, huge differential diagnosis. One of the least discussed etiologies of epiphora is punctal stenosis, unfortunately. When it occurs, the most common presenting complaint is going to be tearing, for sure. But some patients may have vague complaints of ocular discomfort. Lack of consensus as to what constitutes functionally disabling punctal stenosis has resulted in a significant variability in the definition of the condition and hence the treatment. Unfortunately, there is no uniform clinical guidelines for the treatment of the disease. So what is acquired external punctal stenosis? It's generally simply narrowing of the punctum. But to be more scientific, Mohsin Kashkouli from Iran had a lot of contribution to this disease in the literature. So he proposed in 2003 a definition of a punctal stenosis that is less than 0.3 millimeter on microscopic slit lamp examination, or the inability to introduce a 26 gauge needle without punctal dilatation. Some authorities define punctal stenosis to be unable to pass Bowman's probe size 00 without punctal dilatation as well. What's the prevalence of this disease? Again, it's variable. It's still unknown, with reported rates rating between 8 and 54%, depending on the settings, demographics, and probably the inter-observer variability. One of the largest case series was done here in Jeddah by Dr. Amal Bukhari from King Abdulaziz University Hospital, King Abdulaziz University, in which she studied or recruited prospectively 682 patients coming to a general ophthalmology clinic. Among those, 54% they had some sort of punctal stenosis. The strange fact, 58 of them were asymptomatic. Another large study from Spain discovered that 17% of the general population, they have punctal stenosis. Another retrospective chart was done in Canada, in which their number of patients was around 150, but this was a tertiary referral hospital, and they found that 8% of patients complaining of tearing to have punctal stenosis. What about the male to female ratio? Again, it's a controversial issue, but most of the literature thinks that it's more common, predominant in females. Keshkuli and Offit and their team, they found almost like 70% of their patients to be females. And they suggested that the postmenopausal hormonal changes might be accountable for this. Jennifer Murdoch and Wendy Lee, out of their 50 patients, they found almost the same percentage of 67%. One of the largest studies upon this was coming from the UK as well, in which Shahid and her team studied the 200 patients. 60% of them were females. The same result was also reported by Muhammad Javeed Ali from India. The large study done by Dr. Amal Bukhari did not show that statistical significance between the gender difference. But again, that was a general ophthalmology, that was a patients recruited from general ophthalmology practice. I won't go through the anatomy and physiology a lot. I'll just need to remind myself and the audience about some facts about the puncti. The lacrimal puncti are positioned at the medial part of the eyelid margin, of course. The upper punctum is generally located 0.5 millimeter medial to the lower one, and it's usually more obliquely oriented. The importance of the puncti in the lacrimal pump mechanism is very crucial. As with eyelid closure, the puncti are usually opposed against each other, which helps a lot in the lacrimal pump mechanism. Generally speaking, the punctal size is usually between 2 to 0.3 millimeter, and the lower punctum is slightly larger than the upper, and there is no gender difference in punctal size between males and females. What about the etiology of this disease? A lot of disorders were related and associated with this condition, most commonly aging, and most importantly, chronic blepharitis. So chronic blepharitis is the most common cause or the most common association with the punctal stenosis. It is still unknown what's the mechanism, but we think that the low-grade inflammation that is happening at the lid margin contributes to this. Dry eye syndromes, lid malposition, especially ectropion, OCP, ocular cicatricial pemphigoid, Stevens-Johnson syndrome, graft versus host disease are all also related. More and more nowadays, we're seeing more infectious conjunctivitis causes punctal stenosis. Any conjunctivitis, to be honest, viral, trachoma, herpes simplex, any conjunctivitis can lead to punctal stenosis. It is very important as well to ask your patient about the use of topical medications, as most, if not all, anti-glaucoma medications were related at some degree of causing punctal stenosis. More and more, nowadays, we're seeing more use of topical mitomycin C in conjunctival neoplasia, and this also contributes and increases the incidence and the cause or the association of punctal stenosis. Some systemic medications, especially 5-fluorouracil and other chemotherapeutic agents, are related, and trauma, facial radiotherapy, and idiopathic causes have all been linked. I'm not going to go through the mechanism because, again, it's still unknown. They're all like theories. But we believe that a low-grade inflammation that happens over months and years contribute to the narrowing of the punctal with time. What are the risk factors? Again, age, being a female, chronic blepharitis, topical medication, especially anti-glaucoma, and chemotherapy for malignancies. How do you usually assess those patients? Now, it's important for us to to differentiate, is this a real epiphora or lacrimation? By real epiphora, we mean tearing that is related to the lacrimal system pathology in general. Always examine and check for blepharitis, assess the lid laxity, and always pay attention to if the patient has ectropion or excessive laxity. Look for malposition, examine the anterior segment, make sure that there is no conjunctivitis happening. Tear breakup time, corneal staining, dye disappearance test are all important. And finally, do punctal dilatation and pass your probe to assess the canalicular system and the common canaliculus as well as the nasolacrimal duct. This is what's mentioned in the. This is the most common modality to grade epiphora. It's called Monk grading system. It's not a practical one for you and me to use in your daily practice, but it's important for studies and research, where grade 0 is no epiphora and grade 5 is constant epiphora. Again, it is because of the work of Muhsin Kashkouli from Iran that contributed to the literature of the definition and the grading of the punctal stenosis. Before 2003, there was a huge discrepancy in literature. What is punctal stenosis and what's normal puncti? So Kashkouli and his team in 2003 proposed a grading system that is still the most clinically acceptable nowadays to be used for assessment of punctal size. His team did another study in 2008 to confirm the inter-observer reliability, and they found their results consistent as well. So let me go through this quickly with you. I will not start from the beginning, so let's start from number 3. Don't go through 0. So number 3 is normal. Number 3, grade 3, is the normal punctum that you and I have. Grade 2 is smaller puncti, but still recognizable. Grade 1, in which there is a membrane or a lidative membrane over the punctum, and grade 0 is punctal atresia. There is no puncta seen at all. 4 and 5 are larger puncti, in which we call them clinically or label them as punctal slit. These are the sketches or the photos from the same original article by Kashkouli. This is grade 0, in which there is atresia. You can't see any punctum here. You can't see. Grade 1, there is a punctum, but there is a membrane over it. Grade 2 is a recognizable punctum, but small, and this is grade 3, which is normal. Grade 4 is a punctal slit that is less than 2 millimeter, and grade 5 is a punctal slit that is more than 2 millimeter. The rest of the Grand Round will talk about the management of this disease. So always, please always treat blepharitis. Actually, a lot of studies in the literature, they did not start including or recruiting their patients until they treat blepharitis for 2 or 3 months. So treat blepharitis before you include your patients in a study, and even during or even after doing your surgery or your management, still treat blepharitis because it may contribute a lot to the success of your procedure. Treat dry eyes and exclude other causes, as mentioned before. Now, the treatment option or treatment goal is easy. The basics is to enlarge the punctum, whether surgically or non-surgically. Sometimes we put prosthetic material into the punctum to overcome the possibility of fibrosis or restenosis. And all these methods were tried in the literature. Of course, we will not go through all of them, as some of them are obsolete now, some of them are not effective, some of them are still evolving, but people in literature tried a lot to overcome this disease. I'll just refer here that the repeated punctal dilatation and the perforated punctal plugs are considered non-surgical treatment for punctal stenosis, and the classically done procedure is the 3-snip procedure, but it started by 1-snip, 2-snip, and then evolved to a 3-snip punctoplasty. Recently, the use of mitomycin C with the punctoplasty, the insertion of mini-Minuca monocanaliculaire stent, bicanalicular stenting, or the self-retaining bicanalicular stenting have been all with good results, to be honest. The perforated, the non-medical or the non-surgical treatment of punctal stenosis, the perforated punctal plugs are usually easily suitable. It's an office procedure. It's reversible. It's well tolerated usually by patients, and the advantage over this is the lacrimal sphincter is not damaged or is not disturbed. The rationale of this, for sure, logically, is the long-standing dilatation of the punctum to prevent the recurrence or the stenosis. However, the evidence of the long-term efficacy of this method is still uncertain in literature. The perforated punctal plug is very similar to the regular routine punctal plug that we used to use for dry eyes, in which we occlude the puncti. These are just examples. I'll try to mention each modality and one or two paper or study that supports it. Ozgur et al. From Turkey reported this and published the result at the Saudi Journal of Ophthalmology in 2014, in which they did retrospective study. They included 45 eyes with punctal stenosis, and they inserted a perforated punctal plug in all patients, and they kept the plugs for 6 months, which is, I think, is a key factor for their high success rate. We used to keep perforated punctal plugs less than this, but with time, people started to keep them more and more because of the chronicity of the condition. So the plugs were tolerable in 93% of patients. They reported an improvement of 91% at 6 months and 82% at 1 year, with only perforated punctal plugs. 2 eyes had early plug drop-off, and 1 eye had pyogenic granuloma. So they recommended in their study to use the PVP-coated plugs, which are hydrophilic. The old version of the perforated punctal plugs were hydrophobic, in which a lot of discharge and complaints from the patients from the discharge and the foreign body sensation was there. And they recommended to leave the plugs there for 6 months. As a limitation of their study, they did not define what was their anatomical success, and they did not use the Monk scale system for grading of epiphora. Shifting gears to surgical treatment now, the punctal snip procedure is an old procedure, actually very old. It was first time used in 1853, and this is the 1-snip procedure, in which a vertical incision is done at the vertical puncti, and that's it. The procedure is definitely interfering with the capillary action of the canaliculi, and it had a high failure rate, and nobody nowadays uses one or 2 snip procedures, especially with the prevalence, especially with the better surgical options available nowadays. The famous or the most common classical treatment of this is the 3-snip punctoplasty, or the 3-snip procedure. It was first used or tried in 1950. Basically, it involves a vertical cut of the vertical canaliculi and then a horizontal cut of the roof of the canaliculi, and then creating or connecting the flap together. Though it has a good initial success rate reported in the literature, but people started to believe that it can permanently damage the proximal canaliculus and the lacrimal drainage system, It prevents the apposition and the occlusion of the puncti during eyelid closure, and it definitely interferes with the active pump vacuum mechanism. Later on, a modification of this technique was done, changing the triangular shape of the incision into a rectangular shape, which was thought to be more proper and more anatomical. We'll go through this in the next slides. It was Melanie Chack and Fiona Irvine from England who did a strange study, to be honest. It was published at the Ophthalmic Plastic Reconstructive Surgery in 2009. Though their study was easy, they did a retrospective study of their patients, and they recruited 108. They did two groups. One group received the rectangular 3-snip procedure, and the other group of 49 the rectangular and 59 the old-fashioned triangular 3-snip procedures. And the two groups were comparable with the demographics. Although they did not find a statistically significant difference in the success rate between the two groups, but they reported that there was a trend of for patients to be more symptomatic post-operatively despite a patent punctum following the triangular punctoplasty. Almost like 17% with the triangular punctoplasty, they were still complaining of symptoms. In contrary, 10% with the rectangular, but again, results were not statistically significant, and that's why they said there was a trend. 5% of their patients had recurrent stenosis, but some of those had OCP, and we know the chronicity of the disease, and another patient had an ectropion, and this tells you that the inclusion and exclusion criteria was not very well defined. This sketch is from the original article of Chuck and Irvine, and this is the old triangular 3-snip procedure, the one we used to do, and this is their proposed rectangular 3-snip procedure. Basically or simply, two vertical cuts are done on the vertical caniculi and then just cut the base. Of course, you can see here that the horizontal canaliculus is not touched. So, in traditional triangular punctoplasty, the vertical caniculi are opened, which causes more anatomical destruction and prevention of the apposition and occlusion of the puncti, and then interference with the active pump mechanism. However, in the rectangular punctoplasty, the anatomy is more preserved and the physiology is more intact. And I quote this from their study that they proposed. They said, "We propose that rectangular punctoplasty is a simple, safe, and quick procedure that maintains the normal anatomy and physiology of the puncti and the canalicular system, and should be considered as less destructive than the traditional triangular punctoplasty." To be honest, this is a paper of 2 pages only. It was a retrospective. No inclusion or exclusion criteria were mentioned. No definition of anatomical or functional success. They did not use any scale of whatever, either KKESH grading system for punctal stenosis or Monk system for epiphora. And their follow-up was very variable, from 8 days to 2 years. Though the significance and the impact of this paper on a lot of ophthalmologists and oculoplastic surgeons was huge. So a lot of people with time, they thought the logic and the rationale that they proposed in their study is very logic. Let's not destroy the horizontal punctum, let's preserve the anatomy, and let's keep the active pump mechanism intact. And people, they started differing from the old triangular one to the more rectangular 3-snip procedure. For example, Muhammad Javid Ali from India, who was here 2 years back, did review his patients retrospectively, all done by him, a single surgery over 3 years. And he mentioned that he did the rectangular punctoplasty for all patients. They included 145 puncti, and the complete resolution was achieved in over 74%. However, I would say the low success rate in his result and his study was because of the inclusion and exclusion criteria. 10% had functional epiphora despite a patent system, and 10% were having obstruction to the punctum. So the punctum is not the one to be blamed. Jennifer Murdoch and Wendy Lee from Bascom Palmer reviewed their almost like 50 patients, all done by the same surgeon, Wendy Lee, and they published their results in Orbit 2015. And they had a strict inclusion criteria in which they had only patients with primary punctal stenosis were included. So no canalicular, no common canalicular, no whatever. They had a success rate of 86% of their patients having rectangular 3-snip procedure alone. The other 14% had recurrences, so they did another 3-snip procedure, but this time they used either a donut stent placed or mini monoca monocanalicular stenting. In their study, they encountered some adverse effects or complications, mainly because of the stent, in which one patient had actinomyces israeli infection and one had a staphylococcus aureus infection. Shifting gears to other modalities in treating punctal stenosis, monocanalicular stenting or mini monoca is well known since long time, and it was proposed and used hugely in canalicular laceration. So it consists of a circular perforated collarets that usually gives like a very good stabilization over the punctum and prevents the migration of the canaliculi of the stent. The punctal and canalicular dilatation and probing to the lacrimal sac should be undertaken meticulously to ascertain the length of the stent, and usually we leave 2 millimeter more of the stent before we cut it. Kashkouli again did one study using it was a prospective study. They recruited 53 eyes, in which they did a one snip punctoplasty and mini monoca insertion was done. They reported a complete functional success in 77% of patients and 7.5 as a partial success. But their anatomical success was great, reaching up to 96%. The key factor that contributes to the functional success, the low rate of functional success here, was that 60% of their patients, they had associated canalicular and common canalicular or the internal punctal stenosis as well. So that's why the punctum was not the one to be blamed alone. So they proposed in conclusion that mini monoca can address 2 problems in patients with acquired punctal stenosis. The first is to prevent restenosis for sure, and the second one is to address and treat any associated canalicular or common canalicular diseases or stenosis. This is an example of this is a photo from the same study. This is the mini monoca monocanalicular stent. This is a patient with grade 1 on Kashkouli grading system punctal stenosis. This is the mini monoca inserted, and this is the punctum 6 months after the removal of the mini monoca stenting. You can see the difference for sure. Another study that was done by Morris Harstein from Israel and Lior Or, they recruited 40 patients in which all had punctal stenosis secondary to perineal allergic conjunctivitis. So they recruited those patients from their clinic, and they did a mini monoca monostent insertion, and they followed their patients for almost a year and a half. All patients had grade 2 according to KKESH grading system, and they reported 95% success rate in the functional improvement on patients. However, I had a concern when I was reviewing this article that they mentioned clearly that during the use of the mnemonic and stenting, there was no use of topical therapy while the stent was in place, or even when it was removed. This is like a bit difficult to digest, since these patients, they have a perineal allergic conjunctivitis, so they have allergy all over the year. How can we control their disease over a year or a year and a half without topical medication? I found that like a bit awkward. Though their success rate was high, and they reported up to 95% success rate. Another method of stenting, or putting a prosthetic material in the canaliculi, is the self-retaining bicanalicular stent. It's a way to, it involves both canaliculi. The good thing here that the stents are being usually fixed after the common canaliculus. And this is an example of it. Now, if there is any associated canalicular disease here, or canalicular stenosis, or common canalicular stenosis, this method can usually address. So another study came from Greece, published in 2013. This one was a bit interesting. It was a prospective study. So they recruited 32 eyes of 16 patients. And they did, in group A simple rectangular 3-snip procedure. And in the fellow eye, they used it as a control. And they did a combined punctoplasty with insertion of the self-retaining bicanalicular stent. And they followed the patients for 6 months. Their results, when combined together, both the absolute and partial functional success, was very high in the stented group, almost like 15 eyes out of 16, in contrast to 6 eyes in the group that received only punctoplasty. And that was statistically significant. Stents were removed usually in 6 weeks. These are some photos from their study. This is the way the stent was inserted from the lower and then the upper, and this is the way it looks by the end of the procedure. This is the same patient. This is a photo of the same patient. This is the eye that group A that had only punctoplasty after 10 minutes of dye disappearance test, and this is the fellow eye in which the punctoplasty was associated with insertion of the self-retaining bicanalicular stent. So they mentioned that the self-retaining bicanalicular stent is a patient-friendly solution, and it aims at mechanical dilatation, and it usually addresses both the canalicular stenosis and the common canalicular as well. They noticed this also in their study, as 60% of their enrolled eyes had an upper punctal stenosis or canalicular stenosis as well. So they concluded that the self-retaining bicanalicular stent was an effective way of dilating the common canaliculus and both ends of the canaliculi as well. The long-term results and the tolerability of the stent was also assessed, and they found that it had a good toleration by patients compared to mnemonic. My last article that I'm going to mention today is a recent study done by Dr. Naif Sleiman and Dr. Adil Sahibani. It was published on the Ophthalmic Plastic Reconstructive Surgery Journal in 2019, and actually I would like to congratulate the authors. That was the result of the thesis of Dr. Naif Slimani, who is a third-year resident. They retrospectively recruited 98 eyes operated all by the same surgeon, Dr. Sahibani, in which patients had punctal stenosis secondary to allergic conjunctivitis. So 85 eyes had a pigtail probe inserted, and then a hollow silicone tube was fixed. And on the 13 remaining eyes in which the passing of the pigtail was not possible, they stented the patients with the routine Crawford bicanalicular stent. The stents were kept for 6 months, since this is a chronic disease with in a high prevalence of allergic conjunctivitis area. And in 6 months' time, after removal of the stent, they reported an anatomical success of 91% and a functional success of 87%. 4 eyes had early prolapse of the stent. 2 out of 4 did show some improvement, and 2 returned back and got another restenosis. So in conclusion, acquired punctal stenosis can be a bothering disease to a significant number of patients in our clinic as a result of visual disturbance and a social embarrassment. Unfortunately, there is no uniform clinical guidelines for treatment of this disease. Moreover, comparing the different treatment options for acquired punctal stenosis is difficult due to several factors, including very limited numbers of studies on any given procedure, the deficiency of a universally acceptable method of definition or grading the punctal stenosis, as well as the standardization of the anatomical success. The failure to address, this is important, the failure to address the presence and the treatment of chronic marginal lid margin inflammation, especially chronic blepharitis, in the studied population, and if any treatment was given, is another factor that may affect the result of the majority of the published articles. At the present time, we believe that the quadrangular or the rectangular 3-snip procedure seems to be the most commonly studied procedure with a high success rate due to theoretical preservation of the lacrimal pump mechanism. The risk of fibrosis and restenosis is present in all available modalities of treatment. However, we can overcome this by using an adjunct punctal prosthetic, but still the restenosis is possible. Blepharitis should be treated aggressively in conjunction with the treatment of punctal stenosis. Canalicular, common canalicular, and nasolacrimal duct stenosis or obstruction all might be associated with acquired punctal stenosis. Because of the high level of associated internal punctum and canalicular stenosis with punctal stenosis, a procedure should address both problems and pathologies together. By the conclusion of my presentation, I would like to acknowledge the help of Dr. Naif Sleiman and Dr. Ahmed Rabi'an, who helped me a lot in putting out my presentation. Thank you very much for your audience, and these are my references.
Thank you so much, Dr. Hattan, for a really interesting review.
No, I'm not.
لا بالعكس والله. Any question from the audience?
أستاذي ما يحتاج.
Thank you very much, Hattan, for this. In fact, I believe it one of the most challenging subject facing daily by ophthalmologists, either general or oculoplasty. I believe that punctal stenosis is a very, very difficult subject, not because of the treating of the disease by itself, but diagnosis itself. In my clinic, and maybe Dr. Adil and you know that referral to your clinic, 70 to 60% complaining of tearing.
Yes.
And it has been referred from my other colleagues in other subspecialty. I wish this lecture or this grand round was attended by many other non-oculoplastic consultants, so they know the problem before they refer the case to you. In fact, the most important point, as you mentioned before, is you have to know what's the reason of tearing, because 90%, I believe, mostly is non-related to punctal stenosis. In my opinion, the reason for this tearing for all patients I'm seeing in my clinic, only 10% I'm seeing patients that truly, because of the punctal stenosis, that need being treated, as you mentioned in your lecture. My question here also for you and Dr. Adil, also regarding the diagnosis of the punctal stenosis. In your paper, Dr. Adil, have you, because you said it's allergic conjunctivitis patients, so they still continue using the same medication while the patient on a stent, or even you stop the medication during that?
Yeah, what happened in patients with allergic conjunctivitis? They come with active phase. So before thinking about stent, we need to start them with topical steroid and antihistamine and mast cell stabilizer. We wait for 6 months, for 6 weeks minimum, till things are quiet. And if they still continue having the stenosis, sometimes doesn't go by only topical medication, we put the stent. And we ask them to continue using the mast cell stabilizer and the antihistamine. So we don't stop it. The problem that, allergic conjunctivitis is a chronic condition, and the treatment is not the stent or anything, it's more controlling the disease. And the same thing applies for blepharitis and other condition disease. If you don't control it, the restenosis will happen. The stenosis will happen again. So controlling the primary disease, I agree with you, is really the most important.
Can I totally agree. I think that's why I mentioned that the paper from Israel by Maurice Herstein, they mentioned that they did not use any topical medication while the stent was there. And to be honest, they targeted a more difficult disease than yours. So in Dr. Sahibani's paper, they studied patients with SAC, seasonal allergic conjunctivitis, while in the other paper, they studied the perennial allergic conjunctivitis, which is through the year. I believe both comments are important. Treating, we were in the past, we were in a very rushed to treat punctal stenosis, as you mentioned, Dr. Ayman. But the reality is, other diseases, they contribute to the tearing or the complaint of the patient. It's not only their puncti. Some of those patients, they have allergy. Some of them, they have myelinitis. Some of them, blepharitis. Some of them, dry eyes. So all these should be tackled at the same time. Not telling my patients that, you know what, I'm going to put a stent and your all misery is going to go. No, that's not true. We need to control those diseases, to be honest, before the insertion or before any surgery you plan for the puncti. And this is my honest opinion.
Any other question?
How wide? What's the ideal width of the snip that should be, and was it standardized throughout the studies? The width of that?
Actually, no, but we know from anatomy that the vertical canaliculi is 2 millimeter. So most of the studies we're doing 2 cuts vertically in the vertical canaliculi, and then just cutting the base. So I assume it's less than 2 millimeter. Dr. Adil, you have any comment?
and he has no blepharitis, no lid laxity, no dryness, is typical punctal stenosis. What's your first approach?
That's a difficult one. طيب, to be honest, I personally, I think I'm the least experienced of the audience from the oculoplastic field, but we were taking that disease light. And I think in our society or in our environment, you should be more aggressive. Though I would give the option for the patient, I will start with a non-surgical treatment. I will give him the option and the choice. I will explain to him the possibility of inserting a perforated punctal plug for a couple of months, 3 or 4 months, and then we can recheck if he's okay, symptoms improved, good and well. If not, maybe I'll jump to the next step, which is a punctoplasty with an insertion of a prosthetic material, whether it's mini-monoca or bicanalicular stenting or any other device.
So you don't prefer to go for a snip? After you remove the punctum and still the patient has stenotic, you need to put another tube?
After I remove the plug?
Perforated punctal plug.
If symptoms improved,
no,
good and well. If no,
it's not improved.
Yeah, I'll go ahead with the punctoplasty, yes.
Punctoplasty?
Yes.
Adil? Yes. But do you feel that you take the patient for bicanalicular stenting directly? You know, it's not a clinic procedure. You have to take the patient to the main OR, check him, and at least you can do it under local, I agree with you, but still not all the patient really agree for taking the tube and for this disease. What do you think? Do you explain the patient? Yeah. That's right. That's right. I totally agree with you. This is, I think, the best way that guarantee that mostly the patient have happy with after removal of the tube, in my opinion also. But and the using of mini Minoka, do you have any experience? That's right. Yeah. And the insertion is difficult. I found the insertion of mini
It's not easy, yes.
It's not
Yeah.
easy.
Yeah, it needs
Unless
a
if you
learning
do
curve,
the
you're
same, what Kashkuli did, he did an horizontal slitting, cutting in the puncti, and then he put the the mini Minoka. Maybe
Yes.
it's easier. By
Yeah,
this
you need
way.
to enlarge the punctum. If you want to put the mini monocle, yeah, you need to enlarge the punctum by punctoplasty.
But
either
still,
one
I
or
feel the message that all the resident and they should know that you have to rule out the underlying, especially dryness. Maybe if you close the punctum, the patient has more and more improving for tearing. Thank you very much.
I have a question to Dr. Adel. Dr. Suhaibani, why you preferred the pigtail in your procedure? I mean, why not to put like a Crawford? Yeah, a
No,
Crawford
what
like
happened, I
for
start
all-
using the self-retaining one.
Yeah, جربته
It's
يعني.
way easier to do, but
Yes.
what happened, most of the patients, let's say 90% of the patients, they come with the stent out because really not a self-retaining in most of the patients. Then I moved to pigtail because I know how to train to do it for many, many years. So putting it is way easier for me than Crawford because you don't need to go through the nasolacrimal duct. So that will be easier for the patient. And we do it in the minor room. But some patients, they need some, like, be patient with them to do it because it's not easy. Especially if you, in earlier, let's say, cases it's going to be easy, a little bit challenging to find it. With more experience, it will be easier to go.
And you do all your patients under sedation?
Most of them, yes.
So you take patient to OR, you sedate them, and
Yeah.
and you do.
Actually, it depends on the setting. For example, at the university, I do it in the minor room without sedation. In the private, I have the sedation next room, so I don't have an issue with that.
Okay. And then the type of stent you use with the pigtail?
We use the regular stent. You know, when you use a Crawford stent and you cut it, there is the stent itself. It's hollow,
Okay.
so you can use.
So Crawford.
Yeah.
Modified Crawford.
It's not the Crawford itself, not the metallic one. The
Yes, for
silicone
sure. Yeah,
itself.
fine.
And it's around 0.4 millimeter.
0.46. You're right. Yeah. Interesting. No. Well, to be honest, I reviewed it in a couple of articles. I've never used it. I have some concerns, but I don't know. I mean, it's a controversial issue. Now, we said that one of the causes of punctal stenosis is the use of mitomycin. And at the same time, I do a punctoplasty and I use mitomycin. Yes, I know the literature says we do like a vigorous irrigation, we do like 5 minutes of irrigation, and we do this and this. And to be honest, the results by the end are comparable. على الأقل, at least from the studies that I've ماني متأكد والله مش متأكد. I think it's the same one that they use for glaucoma, maybe 0.4 milligram. يمكن. Adel, you have any experience? Did you try
It
it?
doesn't make sense for me.
Yeah,
so.
it's like a controversial message. We tell patients or residents that they may have stenosis from the mitomycin and we use it. مش متأكد. Not sure.
No, I would rather inject steroid than putting a mitomycin C. Any questions?
حمد.
The population, they don't have common clinical.
أيوه.
So even with experience, you will risk traumatizing one caniculi or one caniculus if you do it. If this patient doesn't have common caniculus, which is what, 1 in 10 or
10%, 10 to 15%. You're right. أيوه.
so. Does it justify, or should we go for Crawford instead?
That's why in the other group, he inserted like 13 patients. 13 out of 98, they did like a bicanalicular Crawford stent.
With traumatizing the caniculus, we might risk kyphosis, don't we?
If you're not using the sharp one, I don't think it should be a problem. بس طبعا يمكن عادل عنده experience أكثر في. Yeah, we don't recommend using the sharp one.
Okay.
So you will always use the blunt one with the opening, and I think it's safer than the routine one that might risk the injuring the canicula.
Thank you.
هو السؤال لعادل بس أنا انزلقت عليه.
But what happens if you go in this direction? Like introducing a bone probe can also traumatize the caniculus. So do we have a problem from that? It's all the blunt tip, so it's the same thing. But the idea is pigtail need practice and need really to be patient with the patient, not to go aggressive. So try really, when you go and try to go from the lower to the upper, be gentle, try several trials. It's not like forcing it. That's why if you force it, you will run into trouble. If you try to go through the normal anatomy, you will get it. And there is some way, like maneuver to stretch the eyelid, how to, when you think anatomy, how to get from the lower to the upper. It helps you in that direction. But it needs patience. What I recommend you, when you finish, I recommend you how to learn it. I would tell you how to learn it. Because not for all the residents to try. Okay, thank you, Dr. Hattan, and thank you all for attending the last grand round.
نعطي الكويز الآن؟ يبدأ الكويز للريزيدنتس ولا للريزيدنتس؟ Can you come forward please؟ لسه باقي على الأصل. نعطيه الكويز باقي على الأصل. شكرا يا عزيز. سهل مرة يا عمي، ما هو اليوم الكويز is very easy يا شباب. So a very easy quiz. It's all lacrimal since we're talking about punctal stenosis, and it's your retreat since summer is coming and it's the last grand round. Inshallah, straightforward. No tricks. باقي حد برا ولا نبدأ يا شباب؟ الساعة 3 صارت. طيب بسم الله الرحمن الرحيم. So case 1, straightforward, no history. Diagnosis, most common cause, and 3 modalities of treatment. straightforward, ما نبغى اختراعات في الأجوبة. واضح ها؟ كويس؟ next ولا لسه؟ الدكتور اللي ورا. طيب case 2 any 3 modalities ها؟ مو ضروري حتى بالترتيب، لا تقول لي 1 2 3 4 any 3. case 2 diagnosis, mention 2 reasons or 2 causes of this, and what's the management. Yes, but anyway, even like in general. الدكتور أيمن بيغششكم يا شباب. يقول the cause is there in the picture. ما هو theory. Though I will take 2 causes even if it's not in this picture. احتمال إنه الصورة ما هي واضحة. So what's the diagnosis? 2 causes and the management. جنيد اللي عارف الأجوبة كلها ما شاء الله. حتى الأسئلة اللي لسه ما حطيتها أعرفها. I'm his mentor, that's why. خلاص عبد الله بيطالع فيه معناته سهل خلص. طيب case 3 برضو بسيط, very easy. What's the name of the stent? And 2 indications or 2 uses. واحد اثنين ثلاثة أعطوا. الفيلم المفروض يطلع من القاعة. والفلوة كذلك. Okay. Clear? تمام؟ طيب. Case 4. This patient has this condition. Easy, straightforward. What's the diagnosis? And if this patient is complaining of tearing, what are the 2 mechanisms of tearing in this patient? يعني diagnosis, gross, واضح. Why do they have tearing? Why do they complain of tearing? 2 causes or 2 reasons or 2 mechanisms. اختيار ولا ايش فيكم متاخرين؟ طيب نعيد لكم اياه. ما في مشكله. هذا السؤال الرابع. This is case 4. بقينا واحده. spot diagnosis, 2 mechanisms of tearing. طيب آخر سؤال برضو again straightforward. Diagnosis. What's the cause? And what's the treatment? هدية الكوز هذا صراحة المفروض 3/4 يجيب درجة كاملة. الدكتور disagree. Okay. I'm going to repeat the first 3 لأنه ممكن بعض الزملاء جاء من الطوارئ متأخر. although أنا أعتقد أنكم أنتوا exempted من الكويز أعتقد بس لا يمنع للفائدة. 1. Diagnosis, most common cause, and 3 modalities of treatment. Case 2, spot diagnosis. What's the mention 2 causes and management. Type case 3, this is a stent for the lacrimal system. What's the name of the stent? And mission 2 uses. الرابع case 4 spot diagnosis 2 mechanisms of tearing, and case 5. يلا حنبدا نجاوب. بسم الله. وين الجواب؟ بس 4 اللي مسلمين. هي دلال داخلين معاك في البيت؟ بتصلحين عندي؟ خلصوا الكلام؟ كلكم قدام اللي على الاقل داخل وكيل بلاستكس. أنا قلت لكم طبعا الزملاء اللي ما حضروا الجراند راوند يمكن خلاص بجاوب أبدأ. طيب actually more than one slide or more than one case came from the grand round, and I thought because during the grand round we feel sleepy, فقلت كويس إنه الإنسان إنه يركز شوية. وأعتقد it's all related to the lacrimal system today. So it's dacryology. مين عندنا R1؟ R1 ها مين متبرع طيب؟ فالنتير الدكتورة من النقاط اللسان. punctal stenosis. Thank you very much. طيب كويس صح. At least someone was paying attention during the grand round. Okay. Then, what do you think? Junaid, what do you think? Muhannad. Actually, it's grade 1, but it's difficult for you to assess or to see this membrane with a one-dimensional photo. So diagnosis, ما اخفيكي كنت ابغى احط واحده من الاسئله واتس ذا جريد، بس حسيت انه تو ماتش، والشيء الثاني يمكن يعني احنا بس عرضنا الجدول بسرعه، يمكن اللي ما شافها قبل كده يمكن صعب انه يجيبها، فاثرت انه نخليها بس diagnosis most common cause. طبعا الموست كومن كوز كنت اقصد بليفرايتس، والدكتوره mentioned this correctly. 3 modalities of treatment. في anyone can add any modalities غير اللي قالتها الدكتور؟ ها؟ ستنت ايوه، بس you need to be more specific. مينومونوكا، بايكانيكر كويس عتيبي، سيلف ريتيننج خلاص. I think you got most of it. طيب كيس 2 متبرع فالنتير. سهل يا جماعه والله قلناه. مين اللي يقول؟ ايوه ايمان. ايمان انت سينيور، انت خليك، نبغى جونيور. ار2 مين في ار2 يا شباب؟ ار2 لا ده لا انت برضه جاوبت السؤال الاول خلاص. ها دكتور تفضل. Pyogenic granuloma ممتاز. Why do you think this patient has the pyogenic granuloma? Okay, so he says trauma. وغير؟ ها؟ surgery. Okay, so surgery. مين عنده تعليق ثاني؟ There's a punctal plug. You're right. وهذا اللي كان أيمن الدكتور أيمن الأيوبي بيقول لكم ترى الكوز موجود هنا. So there is a punctal plug inserted here, and it's a foreign body, so it reacted or it resulted in a pyogenic granuloma. لكن أي أحد mentioned trauma or surgery in general will be accepted. لأنه يمكن again the plug might not be so visible from there. What's the management دكتور اللي بدأ الكيس؟ إيش يعني؟ طيب okay. How frequent you want to give? So which one do you want to give? Ointment or drops? طيب drops. أحد عنده رأي ثاني؟ ما حد عنده رأي ثاني؟ يبغى يعطي drops دكتور. Both. شكرا. Why you don't go aggressive? This is like a big granuloma. Go aggressive. Drops an ointment. If he's a steroid responder, he will respond من أي حاجة يعني لا تخاف. So go aggressive because this if how long you are going to follow your patient هذا المريض. For 3 weeks, 4 weeks. طيب. Do you think this patient will improve on medical treatment? أنا بسحب منه الكلام. إيه قول. اتفقنا مين. Okay. طيب. He will put the possibility of surgery. الدكتور في الأخير. Okay. كويس الكونتروفيرسي هذا. Yes. So this is what I was aiming at. So who wants to remove the punctal plug? That's a problem for you, for me to care at, to care about. But into in the quiz, in the question, yes, I will take the medical treatment, but do you think this patient will improve? So as long as the cause is there, most likely he might not improve. يعني possibly the possibility of surgery is high. Excising this punctal, the pyogenic granuloma, and removing the punctal plug. And later on, you can, after the area heals, then you can think of another modality of treatment of the punctal stenosis. أو ممكن تكون أصلاً هذه البلج حاطينه عشان دراي مسح. So I don't know what's the diagnosis أصلاً عشان أنا I jump to what's next after the treatment of the pyogenic granuloma. عتيبي. Possible بس أنت قصدك after excision? Yes, okay, well taken, very well taken. لكن هنا طبعا احنا طبعا نتكلم عن شيء ثيوري، وفي بعض الهنتس لابد احنا نعطيها كلينيكال، لانه اذروايز ثيوري انتم تقدروا تقراوا من الكتب، لكن الكلينيكال هنس او الكلينيكال سنس حقكم يقول لك انه this patient will not improve on topical on medication only. I need to go and remove that for him. طيب اللي بعده بسيط برضه من الجراند راوند. ايوه ايمن مونو ميني مونوكا اوكي مونو كانيكولار ستنتنج. اللي قال مونو كانيكولار ستنت اكسبتبل، واللي قال ميني مونوكا اليوم احنا الدنيا عيد برضه اكسبتبل. Because to be honest, who can give me another name or another example of a monocanaliculaar stent في الأوفثالمولوجي؟ تعرفوا مين مونوكا؟ هذا هو وغيره. anyone؟ هذا سؤال فيلو، هذا وين الفيلوز؟ ما راحوا. very rare ما فيه very rare، كلها theoretical، كلها يعني experimental. This is the one that is being used for a long time for عشرات السنوات. two uses. إيمان كملي جوابه. تمام. When I mentioned this during the grand round. السؤال اللي بعده فلاح. What do you think? فلاح دكتور. ايوه. نعم. Okay. Left facial palsy. What's the mechanisms of tearing? عطنا. Lid malposition, precisely more, and most likely they have, most commonly they have entropion or ectropion. Entropion ولا ectropion؟ أنا entropion. مين يقول entropion؟ most common. طيب كويس. حاولت أغلطكم بس لا كلكم consistent. So paralytic ectropion زي ما قال الفلاح. Yes. الفيرست نيم عبد الرحمن صح؟ ايوه زي ما قال فلاح. paralytic ectropion يعني lid malposition مقبولة، بس more common is failure of the pump mechanism because of اصلا الفيشل بالسي alone او lid malposition، او حتى هذولي they're more prone to have punctal stenosis زي ما ذكرت انا كمان. dryness، كل هذه causes. في أحد عنده إضافة ثانية؟ دكتور؟ Okay, so what does apparent regeneration do for you to tear, for him to tear? Okay, and what do you call this? Crocodile tear. بس يعني again هذه فيها وعليها على قوله، فيها وعليها. ما فهمتوا. So Muhannad is questioning the whole thing of aberrant regeneration and acquired facial palsy. Theoretically, in the real life, we see it. Hypothetically, I don't know, because this is like the nerves, يعني you can't go. controversies كلها controversies. يعني ما ابغى ندخل في controversial issue عشان الزملاء بس يعني من الجراوند وليس من الكويز، ويعني يطلعوا بفكرة او جواب واضح افضل. الاخير عويضي دكتور. طيب most likely. What surgery? Okay. Any other opinion? ليش endoscopic? Okay. طيب you can do both ما عندنا مشكلة. بس مين اللي قال اندوسكوبيك ثاني؟ عنده جواب آخر؟ طيب good. The نايف كان عندك. Yeah. Yes. والله this is a pointing abscess. يعني بتقول لك افتح. يعني هذا بس والله يفتحها again, anesthesia is painful to inject in the infected area. Not work. لكن again هذا لا يمنع انك انت تكون يعني human يعني تكون رحيم بالبيشنتس. some people they used to open this without anesthesia. طيب يعطيكم العافيه. يلا نايف تعال. سهل ها؟ في اي سؤال صعب ولا سلايد مش واضح قولوا لي عشان we take that into consideration في التصحيح. تبغون نبدا؟ خلينا نخلصها بعدين نصل. كمل ربع ساعه. خلاص ممتاز. هلا كيفك؟ قلت لهم من جد اللي اعطيتك الاسئله؟
لا لا
ترى ما اعطيته اسئله والله امزح. الحمد لله. انت كيفك؟ وين حقك سلايد؟ هذا طيب. يلا يا شباب نبدا الكيس برزنتيشن. ايش رايكم؟ 1 كيس نخلصها وبعدين نصلي. ها 15 minutes 20 minutes ونمشي.
We can start, Doctor. Yeah. بسم الله الرحمن الرحيم. السلام عليكم جميعا. My name is Naif Suleiman. I'm a third year resident. Today I'm going to present this case which was provided to me by Dr. Hattan, whom I would like to thank for his kind supervision. I would start first with the case scenario. Our patient is a 42-year-old gentleman, medically free. He started to notice this right lower lid mass that was slowly growing over the past 3 months. He had no pain and no discharge. 1 month back, he was seen in a private ophthalmology clinic, and he was told by his physician that this was a chalazion. and for that he underwent a Calesian excision surgery. However, post-op, this lesion started to grow up again on the same location. The patient noticed this lesion is getting larger with time with no response to the surgery he had before. Therefore, he was advised by his physician to be seen and seek another center for another opinion. This patient has an outdoor occupation, which he had a fair amount of sun exposure, but however, he had no personal or family history of any malignancies before. His clinical examination was unremarkable, as you can see, normal VA and IOP. He had only right lower lid swelling involving the lid margin with skin ulceration. Other than that, his examination was unremarkable. This is his picture. As you can see here, this is the right eye of the patient. You can see a mass that is growing on the lower lid, on the central portion, involving the lid margin, causing a mechanical ectropion for the patient. And here, slightly more zoomed in picture, you can see a minimal ulceration on top of this lesion. So the impression was that this could be an inflammatory versus neoplastic mass. So he was given a trial of topical Topradix ointment, and he was given a follow-up in 1 month period for reassessment. The patient came back again in 1 month. This is his lesion. As you can see, he had no improvement whatsoever. And in fact, the patient was complaining of more tearing because of the mechanical ectropion and minimal tenderness. So at this point, the diagnosis became going more toward the neoplastic origin mass. So the plan was to go for complete surgical excision with ectropion repair. We took...
Stop here. So guys, from the picture we saw, what do you think is the most likely differential diagnosis? What do you think from the picture? قبل ما أخذناه على السيرجي, what do you think? What's the most likely diagnosis here? basal cell. مين اللي يقول sebaceous؟ دلال ليش sebaceous؟ عشان انه كان عنده شيء يعني location. Basal cell comes to the lower leg. It's a Chalazian mimicker قصدك؟ الشريف اخوان عندهم other thoughts. طيب في مجموعة قالوا basal ومجموعة قالوا sebaceous. Any other thoughts؟ could be squamous طبعا كل شيء, لكن خلينا نرتبها 1 2 3. I would go with basal. I thought it's basal. Common things occur commonly. It's ulcerating. It's in the lower lid. ارجع شوي معي. Now لا معلش ارجع للمانجمنت. Now I saw this patient. This is a Yemeni patient. He's non-eligible to our hospital. I saw him in my private clinic. طيب. And I told him يعني بس عشان يمكن الهيستوري يمكن ما يكون واضح لبعض. And I told him this is a suspicious mass and I don't think it's a Chalazian. And I think the one who touched you or operated on you is mistaken. I think we should go for a biopsy and we should take you to OR. And he said, no, I was referred to you by a neurologist, a famous ophthalmologist who gave me Topradix. فقال لي أنا بجرب التوبرادكس for another month. أنا مسافر اليمن أغيب شهر حارجع لك بعد شهر أو شهر وشوية. إذا ما تحسنت ذاك الوقت أنا will go for surgery. يعني بس عشان نكون واضحة بالنسبة لكم. I won't treat this with Topradix. This mass will not resolve with Topradix. وهذا اللي صار مع الوقت. So the first picture was in November الأولى. أيوة في نوفمبر هنا. I felt with the second visit لما جانا it's progressing and it's enlarging in size. هذا هو بياخذ التوبرادكس. And it started to ulcerate more. So it tells you that something is fishing here. That something is fishing here and this is not a benign disease. And you need to explain that to your patients. اسمع تروح هنا نروح بس it's better to have this excised هنا في اليمن في اليابان في المكان. Treating this with Topradix might suppress some of the inflammatory reaction that happens with neoplasia, whatever the malignancy is, they will come after 2, 3, 4 months with advanced stage or lymph nodes invasion or whatever. يتفضل معلش سامح. So طيب كمل. خليني أنا بمشي كمل.
So we took this patient for surgery. As you can see, this is the area that represents the lid mass, and this is the area that represents the lower lid. As you can see, it's roughly representing almost 1/3 to a maximum of 2/3 of the lid area, lower area. So we took this patient for pentagonal excision and canthotomy cantholysis with reconstruction of the lower lid. Day 4 post-op, he came to us again. As you can see his picture, we excised the lid mass, and there is the area of suturing. He was doing fine at this time. He only complaining of minimal tenderness. So the plan was to see him in 3 weeks for suture removal and to recheck the histopath results.
طيب وقف. ارجع للسلايد اللي قبل. Education الآن احنا نناقش الآن. Why did I choose that method of treatment? يعني I'm the surgeon بس أبغى أسمع مني. دكتور تفضل. Okay. So what's the rule? عشان تكمل جوابك. عشان أنا So what's the rule? Why did I do this method? ايوه السايز كم؟ أعطيني. Okay, you 1/3. So is it more than 1/3? Almost, huh? طيب, I agree. But now keep in mind that I need, if this is basal cell, وانت تقول لي هتان انها basal cell, I need to take safety margin.
Yes.
2 millimeter.
Yes.
So half. So I need to put that in mind, that I need to tell him that, listen, you're going to go with another decision here. You need to do canthotomy cantholysis. ليش؟ لأنه this one حتى لو تلاحظوا يمكن حطها شوية وسع هذه red line. So if you want to excise this, you need to take safety margin. So 2 millimeter من هنا و 2 millimeter من هنا, this is definitely more than 1/3. زي ما كان بيقول الدكتور. Is it 2/3? I don't think so, but it was like almost reaching like half.
Yes.
That's why I know that I can't use this directly. I need to do something. ومن هنا I went with the canthotomy cantholysis. This is an important rule for you that to know in your clinical practice and also in the exam. ممكن يسألوك يجيبوا لك زي كده مثلا ماس صغيرة أو كبيرة يقول لك أو are you going to construct this؟ هذا سؤال البورد مو R1 ولا R2. هذا سؤال البورد خلاص. لما أشوف أنت في المودلز تعرف كيف تفكر وتعرف على الأقل البيزكس اوف ريكونستراكشن حتى لو ما حتسويها بس على الأقل تعرف البيزكس. تمام؟ So canthotomy cantholysis and then during the surgery it was acceptably approximated. يعني الصورة الآن نشوف.
Yes, this is his picture. Day 4 post-op. As you can see, the lesion was approximated in a good way. The patient had only minimal tenderness at that point, no other complaint. He was satisfied at that point, and we gave him a future follow-up to recheck his histopath result. And based on the result, we will put the future plan. So this is his pathology report came out. So the nodule that was sent to the histopath lab showed pleomorphic cells, high nuclear to cytoplasmic ratio, prominent eosinophilic nuclei, atypical mycosis with lymphocytic infiltration. So all of these elements are features of a malignant mass. But this is not enough to give us the exact diagnosis. So we sent another sample for immunohistochemistry for future subtyping. So
يعني كالعادة الباثولوجي أحيانا ما يعطوك straight diagnosis. يقول لك this is malignant وما عارف إيش هو. We need to do more staining و. So this is what was done. At least we confirmed that this is a malignant tumor.
Yes.
وأعتقد من زمان نسيت. أظن we sent the stain للسلايد للحرس وبعد كده للجامعي and they confirmed the data.
Yes. The immunohistochemistry came out to be positive for many markers for T-cell lymphoma. So the tumor was consistent with ALK negative anaplastic large cell lymphoma, which is a very rare subtype of T-cell lymphoma.
فكر ولو 1% إنه this is lymphoma. مش أنا. Not me. I've seen lymphoma. مين جاء في خطر في باله إنه this could be lymphoma. So that's why حتى أنت we tend to tell our patients with basal cell it's the most common, it's the most صحيح إنه malignant لكنه benign عادة يعني it doesn't like metastasize, it doesn't like it has very slow progression. Don't jump to conclusions to your patients. Tell him that listen, most likely this is malignant, you need to examine it, and then we'll talk about the result when the pathology comes from that. If يعني sometimes people خلاص يجي this is basal cell. Well, you know, it's like a big, it's a good cancer that you could have. سمعت برا. لكن you don't know what surprises might be there. أنا ولا 1% فكرت إنه ممكن يكون lymphoma. At least lymphoma usually doesn't have this presentation. لكن سبحان الله كل شيء له أحكام.
So the patient came to us again in the clinic. At this point, he was doing well. He has no pain, no signs of recurrence. The tenderness resolved, no palpable lymph node. He's not reporting any B symptoms of lymphoma. So the plan was to refer the patient for systemic workup to see if there is any signs of metastasis or primary origin. So we sent this patient. All systemic workup was done for him, including blood test and examination of the patient. We did for him CT, chest, abdomen, pelvis with contrast, and it showed few small cervical lymph nodes. As well, they did for him CT guided biopsy, and it was negative, fortunately. So all of these examinations and lab work came out to be negative, and with no signs of metastasis was found. And that was the last time you saw him, doctor, in the clinic. Yeah. So in the second part of the presentation, I'm going to talk in brief about lead lymphoma and what's the prevalence, what's the management usually we do. Lymphoma, as we all know, is a malignant neoplasm that originating from B cells, T cells, or less commonly, natural killer cells. It has two main subtypes, Hodgkin and non-Hodgkin lymphomas. It can affect the eye, as we all know, intraocularly, or it can affect the ocular adnexa, the lids, conjunctiva, and the orbit. The ocular adnexal lymphoma is a localized form of systemic lymphoma affecting the orbit, lacrimal gland, conj, and so now I'm going to talk specifically about eyelid lymphoma. So the eyelid lymphoma is defined as lymphoma infiltrating the preseptal tissue, meaning lymphoma infiltrating the skin, subcutaneous tissue, and orbicularis muscle. This corresponds to the anterior lamella of the eyelid. It has been described in patients with different variety of ages, but it occurs more common in older patients with slight male predominance. Although we see it in younger population with some subtypes like Burkitt lymphoma, but the majority of patients are old with slight male predominance. Many factors has been linked to ocular adnexal lymphoma, such as HIV, immunodeficiency, and some types of viruses like Epstein-Barr virus. So what's the prevalence of eyelid lymphoma? Is it common? Is it rare? So it has been reported that lymphoma of the eyelid constitutes for only 5% of the ocular adnexal lymphoma, which include the lids, conj, orbit, and the lacrimal gland. And I found this very nice article. This is a review article I found. This article was carried out in various countries with many authors from different fields. And the span of this review article, it went back 50 years in the past. And they collected all the published cases and case report of eyelid lymphoma. They collected 199 cases that was published since 50 years. This is a very beautiful schedule I found in this article. It shows that lymphoma of the eyelid can be of B-cell origin or T-cell lymphoma. It is roughly 50-50%, so half of the cases are B cells and half are T cells, one of which is, like in our case, the anaplastic large cell lymphoma, which is somehow rare compared to the other types. Now, how does the patient present? It is almost very difficult to diagnose lymphoma just by examination. So you should keep in mind and take the patient as a whole, history, examination, and investigations. So in examination, the patient may come with swelling mass. Usually it's described as rubbery mass in the box. Ulceration, it's more common with T-cell lymphoma. It is reported in this review article to be 36% of patients with T-cell lymphoma, like in the patient in this case, and 5% only in B-cell type, while B symptoms and lymphadenopathy is seen more with B-cell lymphoma. Lymphoma lymphoma of the eyelid can be a part of a systemic disease, and it can be primary with local spread. So in this review article, they reported that 24% of lymphoma were secondary to lymphomas originating elsewhere in the body, and they specified mantle cell lymphoma to have high risk of systemic disease. B-cell lymphoma has more chance of local spread to the orbit. In this case, they had 34 patients out of 50 patients who had local spread to the orbit, while T-cell lymphoma has more chance of local spread to the skin. That's why it has more ulceration, such in this case. So what's the management? I didn't specify or went deep into the details of the management. I just brought the main management that is used to treat lymphoma. So radiation therapy or radiotherapy is a well-known treatment for lymphoma, and it can be used as primary, or it can be used to decrease the size of the tumor prior to surgical resection. Chemotherapy can be used as well in systemic diseases. Surgical excision can be used alone or in combination with all of these therapies. Some types of lymphoma, such as CD20 B-cell lymphoma, we can use monoclonal antibodies or corticosteroid. You can use either one of these or combination of both. All has been used in the literature with variable success rates. What about the prognosis? Prognosis of lymphoma depend on many factors, one of which is the histological subtype, which is the most important prognostic factors. Some types of lymphoma, such as natural killer T-cell lymphoma, has very poor prognosis, whereas, such as in our case, the anaplastic cell has good prognosis. In this case, in this review article, they had 12 patients, 10 of which had disease-free survival after surgery alone. Such in our patient, we did for him only surgical resection or excision of the lesion. Unfortunately, we lost follow-up with the patient, but at that time he showed no signs of metastasis. Secondary diseases, high-stage disease, or other the presence of the B symptoms, which fever, anorexia, weight loss, are predictors of poor prognosis. So, as we all know, it's mentioned in most books that lymphoma of the eyelid is very bad and it has very high chance of metastasis, but this is not always the rule. Because this doesn't apply always, at least for some subtypes of lymphoma of the eyelid, such in our case, the anaplastic T-cell lymphoma, 10 of the 12 cases that were published had good prognosis. So the message that I want to deliver in this presentation is that lymphoma of the eyelid is a rare disease. Almost only 199 cases were reported. Because lymphoma of the eyelid is rare, the diagnosis is often difficult and the correct treatment is often delayed, with the first tentative diagnosis of infection or inflammation common. Such in this case, they diagnosed the patient first with chalazion, he came back with lymphoma. Therefore, high clinical suspicion and near follow-up period is needed. Thank you very much.
Shukran, Yanai. Thank you. Any question? So, lymphoma in the eyelid is very rare. What's the most common presentation of lymphoma in ophthalmology? Conjunctiva. ايش؟ with ايش لاكريما؟ لاكريما ايش؟ لاكريما جلاند. اوكي. سو اوربيتال ليمفوما مختلف عن اوكيولار ليمفوما. طيب فكونجنتيفال is considered as sometimes both ocular adnexal او ocular lymphoma. تلقيها احيانا او احيانا لابتكس او whatever. بس eyelid lymphoma is rare. eyelid lymphoma. I have another case which is mantle cell, by the way.
I see.
برضه mantle cell lymphoma. Another rare case. But that one has a systemic disease already.
Yes.
And he presented already with
Yeah.
chemotherapy وبياخذ. So imagine me telling that patient that let's say this is like a simple procedure and we're gonna finish this, you'll go home tomorrow وكل شيء حيصير كويس وبعد كده يطلع الدياجنوسيس هذا ويسووا له سكان ويطلع عنده سيرفايكال ليمف نود زي ما طلع عند هذا وياخذوا له بايوبسي ويطلع فين الفوم. طبعا هو he was lucky that his cervical lymph node biopsy came to be negative. لكن the devil is in the details, so you need sometimes to be more suspicious. And I doubt that the first lesion that he had excised or he had surgery for was a chalazion. I highly doubt. حتى أنا قلت له عندك صور قبل العملية، عندك تقرير، يعني حتى he went back to his ophthalmologist اللي سوى له هذا يعني ما أدري فين في البطحة وشكله حسن الموضوع هذا فحتى خاف اكتب له ريبورت أنا like he might be called for malpractice or something. I couldn't get any photos or like reports. All what I had is his story that he had his chalazion done, incision done. حتى قام يوصف لي طريقة الانسجن حقت الشليزن بطريقة مظبوطة. قال لي حطوا لي كلامب وانقلبوا الجفن وسووا لي انسجن وانا اشوف هذا بعدين جابوا كيوريت قاعد يوصف لي شليزن بروسيجر. I doubt that this was originally a chalazion. Highly doubt. Could the surgery that he had aggravated his disease? Maybe. Maybe. Because that was not a typical presentation of a lymphoma. زي ما قال نايف ذكر عادة تكون rubbery, well circumscribed مثلا, ما تسوي زي السكاتريشيال اكتوبيان اللي كان حاصل عنده. That mass was going into scarring phase. I think that surgery he had contributed to the aggressiveness of the disease that he resulted with. Ulceration, cicatrization, mechanical أو cicatricial ectropion وبعد كده enlargement of the mass as well. Sometimes we need to be more sure. مش أي lead lesion is a chalazion. I'm quite sure that the presentation was not like this. سؤال ثاني هذا عنده استفسار ولا كومنت؟ نعم. سؤال محرج صراحة. Not yet بس سبقك بها عكاشة. يعني not yet published but إن شاء الله we will. ممكن لكن to be honest حتى ما سويت سيرش. أنا مشغول في أشياء أخرى لكن I was thrilled by the article that Naif sent me, and it seems that it's a rare tumor, usually managed by oncology. So I've been following this patient for 2 or 3 visits under the supervision of the oncologist. Then I think he went to Yemen. ما أدري رجع مرة ثانية. قال لي أنا خلاص تعاقدي وحرجع من بلدي. فما I don't know what happened for him in the future. وهذه ممكن تكون يعني نقطة what happens. أحيانا كثير واحد في الكيس ريبورت يبغى يعرف طب إيش صار في المخ. بس أنت تقول الشيء اللي أنت عارفه. Any other question? All clear? كويس. يلا يعطيكم العافية كل عام وانتم بخير. نشوفكم بعد الصيف.
الله يعطيك العافية.
I see.